He's associate professor at the University of Calgary. He has done some incredible research in terms of neuroimaging, and he has written the latest chapter in Continuum on the same imaging in acute stroke. And he's also involved in research related to therapies for acute stroke care. This topic is important because selecting patients based on whether CT, MRI with perfusion imaging, late windows, many of them are still confused in the sense, so many modalities, so many different circumstances. So to get a clear head as to what is the best and are both comparable CT, MRI, and what is the utility of perfusion, this is a very important topic. So without wasting any time, I would request Dr. Bijay Menon to take it forward.
Thanks, Darshan, and thanks for the opportunity. I'll be speaking on imaging and acute stroke. This is my favorite topic to speak on, but my goal would be to tell what we do here in Calgary, which is pragmatic imaging, and essentially focus on those principles. So we all know acute stroke is an emergency, and therefore the most important thing with acute stroke is to balance rigor in patient evaluation with speed in decision making. This is critical, and everything that we do with imaging is premised on this philosophy. So when a patient comes to us here, the focus is on fast clinical evaluation. We call this parallel workflow, which means that we don't actually assess patients in serial order with history first and then examination. It all happens in parallel. So as soon as the patient comes in to emerge, the vitals and ABC are checked, and the patient is being transported to the imaging suite while we're actually taking history. And the history is very focused, essentially trying to find out when the patient was last known, what is the severity of the symptoms, whether there's any prior history of strokes or cardiovascular disease, any contraindications for thrombolysis or endovascular therapy. But the workflow is in parallel. So I want you to imagine that this is what we do. Patients moving along while we're taking the history to the imaging suite. And then the focus is on getting the acute scan. Now, we all know that we need to do imaging in acute stroke, but the question is why? And there are three simple reasons. One is to obtain a diagnosis. You could have an ischemic stroke, as you see in this picture here, but you could also have a hemorrhage. Could be a subdural, extradural, could be a tumor. So imaging is important. Not all acute stroke clinical presentations are strokes. The next is prognosis. We want to know how a patient would do. And imaging is, a significant determinant of prognosis. You see on the right MCA territory here, a huge stroke. The extent is big. This patient is not likely to do well. And so you can inform your patient about prognosis. But most importantly, acute stroke imaging helps to select your patients for appropriate therapy. So you have these questions in front of you for acute ischemic stroke, say, as an example. Will this person benefit from IV thrombolysis? Will this person benefit from endovascular therapy? What would be the risk of bleeding with thrombolysis? What would be the risk of treatment with endovascular thrombectomy? These are questions that imaging can help you answer. And so that is the utility of imaging in acute stroke. So then the next question is, what tool do we choose? And I am aware that in India, there's still that use of the MRI scan. But here are, again, the principles of acute stroke imaging. It has to be fast. It has to be very easy to acquire. It should be available 24/7. The cost of acquiring a scan is important, and then the relative absence of contraindications. So as I mentioned, time is brain. If you can do your scan fast, if that scan is available 24/7 and you do not waste any time in getting the scan, and you do not have to go through a list of contraindications, then that is the modality you would choose. In Calgary and in most places in North America, we have landed on the CT as our workhorse tool. So that is what we use. Amongst the CT modalities that we use is the non-contrast CT head. There's the CT angiogram head and neck. And in select patients, we may use the CT perfusion of the brain. And we'll discuss these imaging modalities. So when a patient comes to us, we get the non-con CT first in the imaging suite. And immediately on the console, we do a rapid assessment. This happens immediately. We're looking for these features on the non-con CT. Is there any bleed? We look for something called the eye deviation sign, look for hyperdense artery sign, then look for early ischemic changes, and I'll show you images for all of these. And then we do the aspects. So this is an example. You see a CT scan, and immediately on the left side here, panel A, you see that this is a potentially a subacute to chronic ischemic stroke. Whereas in this case, you see subdural, extradural, hemorrhage of maybe some subarachnoid component. So you can immediately tell apart a bleed from an ischemic stroke. However, let's first focus on the bleeds. If you see a bleed, you do focus on the location of the bleed. That location of the bleed could be peripheral, so extradural, it could be lobar, it could be deep, it could be intraventricular. But looking at the location, you can actually make some educated guesses about etiology. My guess is most of you are neurologists, so I'm not going through this list, and this is all in the continuum too. You get a good sense of what really is happening to your patient when you look at the scans and look at the location of the bleed. You can also assess prognosis, as I mentioned, for diagnosis and then prognosis. You can look at the size of the bleed and measure that bleed. The most commonly used formula is ABC by 2, based on Kotari's initial work, and measure the volumes in measure the length in centimeters. So take it in 3 planes, and once you get the volume, that would be in ml. If you have a volume more than 60 ml, that is considered not so good a prognosis. If the bleed extends into the intraventricular space along with that volume, you have some reservations about the patient's prognosis. But there are some other prognostic markers of ICH that are identifiable on the non-con CT that are recently published. If you look at this scan here, the panel A on your left, you see these little islands on the periphery marked by those white arrows. That's the island sign. You also see that the hemorrhage itself is not homogeneous. It is heterogeneous with areas of darkness and areas of brightness. That's known as the blend sign. And then here you see an area within the hemorrhage that's quite dark and is not in continuity with the rest of the hemorrhage. This is known as the black hole sign. Now these signs on the non-con CT for the hemorrhage are markers of poor prognosis. My opinion is, and if you ask me why is that so, these are actually markers of heterogeneity, and a heterogeneous hemorrhage to begin with is a hemorrhage that potentially is growing, that is bleeding at that point. And this is, I guess, the reason why these signs on non-con CT scan are considered as poor prognostic markers for intracerebral hemorrhage. Now we focus on early ischemic changes, jumping on from hemorrhage, again on the non-con CT scan. You see this scan, and here I see that the lentiform nucleus on the left side, where I'm pointing out with the red arrow, the borders are obscured. This is obscuration of the lentiform nucleus and early ischemic change. You can also, potentially look at the insula here, and the insula, unlike say on this side here, on the right side, is not very clearly seen. So this is the insular ribbon sign. If you look at the cortex, some of the gray-white differentiation is not well seen. So these are early ischemic changes on the non-con CT. They are suggestions that the ischemia is happening, has happened very recently. But the more important construct to actually identify with acute stroke imaging is the construct of mismatch. And this can be identified on the non-con CT too. So what is mismatch? Mismatch essentially means you are trying to find out if there is salvageable brain vis-a-vis irreversibly infarcted brain. And the only reason we as stroke doctors are in the business of treating our patients is because there is a mismatch, that there is salvageable brain. Because if there were no salvageable brain, then we wouldn't be treating our patients. Now, mismatch, there are different types or constructs for mismatch. There is what is known as a clinical imaging mismatch, which is where when you look at your scan, and the scan be the non-con CT scan, that you get a good sense of the extent of damage to the brain, but then you also get a good sense of the clinical deficit that the patient has, and your neurological assessment of what area of the brain contributes to the clinical deficit. Vis-a-vis what you see on imaging is clinical imaging mismatch. There are pure imaging mismatch constructs too. These include the core penumbra mismatch, likely seen on CT perfusion imaging, the core collateral mismatch seen on CTA imaging, and I'll show you that. The diffusion perfusion mismatch, where you see diffusion, which is your core, and then perfusion, which is the not core, or perfusion minus diffusion. And then there is a different construct called the DWR flare mismatch, which is not salvageable brain, it's a sense of time, and I'll show you that too. But before we go there, I just want you to have a look at this picture here. This actually explains the ischemic stroke pathophysiology and puts into context what we're talking about. So in every ischemic stroke, you have an artery with an occlusion here, which then results in ischemia to the brain. Some of the ischemia is actually very severe, and this is what we call the core. But there are brain regions with less severe ischemia, but which cause dysfunction to the brain. This is penumbra. There is brain region with less flow, but the brain still not dysfunctional. This is, benign oligemia. And so these are the constructs that you'd see. Now, although we call them core, penumbra, and oligemia, as you would see here, it's actually a gradient. And why does this happen? Because beyond the occlusion, some of the brain is actually supplied by leptomeningeal collaterals. So this is important for you to recognize, because most of the imaging that we'll see subsequently is trying to picture this. So all of you, most of you would have heard of ASPECTS. ASPECTS is the Alberta Stroke Program early CT score that came from here, Calgary. It is essentially looking at the MCA region of the brain and assessing that MCA region of the brain for early ischemic changes. The MCA region of the brain is divided into 10 regions from 6 cortical regions, M1, M2, M3, 4, 5, 6, the caudate, lentiform, internal capsule, and the insula. It is assessed at 2 levels, at the basal ganglionic level and at the supraganglionic level. It's a 10-point score. Now, if your patient has a hyperdense MCA sign, which means that possibly there's an M1 occlusion, and you see that the aspects is maybe just M1 and M2 regions are involved, then you immediately know that there is a mismatch. This is because there is a hyperdense MCA sign, and therefore this entire brain is supposed to be ischemic. And then the early ischemic changes are seen in 2 regions. So the rest of the regions are potentially salvageable. Now, this depends on the clinical assessment of the patient. So if this patient has a NIHSS, a stroke severity scale score of 2 or 3, then maybe the remaining regions are all oligemic. But if the NIHSS is 16, then the regions that are not affected are likely to be penumbral. Thus, the aspect score, a good score would indicate, good score would be like 8 or 10, would indicate that yes, there is salvageable brain if the patient has deficits. And a poor score would indicate that, oh, the likelihood of salvageable brain is low. Now, we don't actually, as Darshan would know, we don't, in our normal clinical practice, we're not as granular as measuring the 10-point aspect scale. What we essentially do is look at the scan and ask ourselves, is this a good scan? Which means, oh, very minimal early ischemic changes. Is this a fair scan? Which means, there are some early ischemic changes. Or is this a poor scan? So we don't officially go and score an aspect. We just trichotomize the scan as good, fair, and poor. This is for clinical use. So while you're assessing aspects, as you would know, one thing that's really important is to make sure that the scan quality is good. And an important part of that is to assess the window width. So what I do normally in my practice is to adjust the window width such that on the normal looking side, I can see the gray white matter differentiation really well. People do use some preset windows, but in my experience, it's always better to adjust the windows to make sure that the gray-white differentiation is best seen. You must also be cognizant of motion, as you see here in panel B below. If you have motion artifacts, then you might have a tendency to overestimate aspects. You can see in this case, you might think, oh, this entire region seems involved, but that's not the case. Yes, the lentiform and the insula involved, but the upper cortical regions are relatively preserved. Let's now jump over to this other construct called, people call it the subacute looking change on the non-con CT. This is very similar to what you would call a DWR-FLAIR mismatch. The row on the top shows you panel A is a person having a stroke on the right hemisphere, and then you see the diffusion weighted scan. And then B, figure B here, shows the flare scan, and you don't see much flare changes. So there is diffusion change, but there is no flare change. This is DWR-FLAIR mismatch. Now, interestingly, if you look at that patient's corresponding non-con CT scan, you will see some early ischemic changes, but the attenuation characteristic when you compare it to the other side will actually be subtle. So you'll see subtle early ischemic changes when you do not have DWR-FLAIR mismatch. This is in contrast to somebody else with no mismatch, with no DWR-FLAIR mismatch. So look at the bottom row here. So here you see in figure D, diffusion restriction. I'm pointing out with the arrow here. And then you see flare changes on the diffusion restriction area. And then the corresponding non-con CT shows significant hyperattenuation. So a DWR-FLAIR mismatch has its surrogate on the non-con CT scan in terms of degree of hyperattenuation. No DWR-FLAIR mismatch would have subtle hyperattenuation. DWR-FLAIR mismatch would have subtle hyperattenuation. If you do not have mismatch, then you will have significant hyperattenuation. Now, as you all know, DWR-FLAIR mismatch is a sense of ischemia severity and time. So the patient above who doesn't have DWR mismatch, who has DWR changes and no FLAIR mismatch, so has a mismatch, this patient is presenting early. And therefore, the changes on the non-con CT are subtle. This means that the risk of bleeding with thrombolysis is on the lower side. Whereas in patient below here, this person has no mismatch. So there are DWR and flare changes. This means that this person has either very severe ischemia or severe ischemia over a prolonged period of time, which is what reflects as subacute looking changes on the non-con CT scan. And if you thrombolize this person and the person has reperfusion, there is a higher probability of bleeding. Now, how do you assess just on the non-con CT if you don't have the MR? You just look at the corresponding white matter on the opposite side. And if it is normal looking white matter, compare the attenuation characteristic of the normal looking white matter with the attenuation characteristic on the abnormal side of the lesion. And if the attenuation characteristic of the lesion is lower than the normal looking white matter, that is subacute looking changes, or tells you that there is no DWR-FLAIR mismatch, that there is probably a higher risk of bleeding. So you can compare the attenuation characteristics of the lesion here to the contralateral white matter and make a good sense as to what it means. Lower than the contralateral white matter would mean more severe attenuation and probably higher risk of bleeding. On the non-con CT, as I mentioned, the hyperdense sign is sometimes very well seen. In our experience, you will have to do thin non-con CT scans. The aspects, we normally do a 5 mm average scan, but in order to see the hyperdense sign very well, you would need thin non-con CT scans. Thin non-con CT scans of possibly less than 1 mm. Although in my experience, even 2 to 2.5 mm are okay. Then the reason is partial volume effects with 5 mm scans. You can also see what is known as the eye deviation side. This is, for some of us, this is for rapid assessment. See, this patient is looking here, and essentially, it's a clinical sign. But on imaging, it actually helps you focus very quickly. Oh, like this patient's looking towards the left side, so let me look at the left side first, and then see what is seen here. So it's just helpful for rapid assessments. It's a clinical sign seen on imaging. So those are what we do on non-con CT assessments. So rapid assessments on non-con CT. We'll come to head and neck CT angiography next. And in our practice, we get the non-con CT first, and then we get the head and neck CT angiography. Now, I'm aware that some people still have concerns about head and neck CT angiography with radiation, and then with the issue about contrast nephropathy. And so I wanted to put to rest some of these concerns. The radiation with a head and neck CT angiogram is, if optimally acquired, is to the order of around 7 to 9 millisieverts. If you compare that with a routine CT chest, 7 to 11 millisieverts, or a CT abdomen, 8 to 12 millisieverts. So it's sort of, relatively, less radiation. And then just to put in context, if you take a flight, and you're flying at say 36,000 feet, the background radiation itself might be somewhere around 20 millisieverts. You might expose yourself to that. So this is low radiation overall. And then contrast nephropathy. There are lots of literature on this. There's a seminal paper from the Mayo Clinic group where they clearly point out that the risk of contrast nephropathy in most patients is minimal, especially when they're actually going through the acute stroke workflow. And so the only patients where we wouldn't actually consider doing a CT angiography is when we clearly know upfront that this patient has severe renal insufficiency and this patient is not on dialysis or cannot be on dialysis. So that's the only patient where there's, like we might actually reconsider doing a CT angiography. And then one caveat that I wanted to tell you was if patients are on metformin, then withhold that drug for at least 48 hours after the CT angiography. It's a practice here. So what do you see on CT angiography? Again, as soon as the CT angiography is done, we are able to look at the scans on a console. And the CT angiography helps both with intracranial hemorrhage assessments as well as with ischemia assessments. Now, just to remind you, if we already see on the non-con CT that there is a hemorrhage, then we would only order a CT angio head. We may not actually do a neck. So, that's our practice. For intracranial hemorrhage, you would obviously be looking for abnormal looking vessels because it is vascular imaging. And then you'll also be looking for this sign called the spot sign, and I'll show you some scans. And for ischemia, you'll be looking for the clot itself or the thrombus, location, presence, extent. You look for collateral status. You look for extracranial large artery pathology, and I'll show you some scans. You look for aortic disease. You look for some other pathologies. And then for interventional purposes, you obviously want to look at the arch and large vessel anatomy. So here's the spot sign in a patient with intracerebral hemorrhage. Now look at the yellow arrows here. So that's where the hemorrhage is. And then you see this bright contrast extravasation, that's the spot sign. This is a multiphase CT angiogram. So it is time resolved, which means that the first scan of the CT head is done. And then low radiation second and third acquisitions are repeated. And so we see the spot sign in all three phases. The spot sign essentially means what you see. It is contrast extravasation. And so if there is active contrast extravasation on a CT angiogram, it means there is active bleeding. And if there is active bleeding, you can tell that this patient is likely to grow his bleed or her bleed, and therefore potentially worsen in the next few hours. That is the implication of the spot sign on a CT angiogram. And obviously, if you have a hemorrhage, you could also potentially see neurovascular malformations, aneurysms, dural AVF. All of these can be easily picked up on a CT angiogram. In ischemic stroke, The first thing that we want to know is the presence of a target occlusion. I call this a target occlusion because that is a target for both endovascular thrombectomy as well as for intravenous thrombolysis, but more for endovascular thrombectomies. Now in this scan here, this is the non-con CT scan on your left, you see the hyperdense sign clearly. And then correspondingly in the CT angiogram, you see a mid M1 NCA occlusion. You already know that this person has an endovascular target and should likely go to the cath lab. But there are some other very interesting things that you can see on the CT angiogram. Darshan, am I supposed to stop for questions? Because I see some popping up.
We can take the questions at the end.
Okay, yeah, thank you. So on the CT angiogram, by looking at the clot, you can also assess certain interesting thrombus characteristics or clot characteristics. If you look at figure A here, you see the clot, you obviously don't see the clot, you see where contrast is not seen, but there is, not much contrast in the arterial silhouette. This, in comparison to this panel B here, the green arrowheads, you see that in the arterial silhouette, that there is some contrastation. And then in figure C here, you see that there is not just some contrastation, but there are some linear streaks. These panel B here and panel C essentially mean that there is some blood flow through the clot, or that the clot is maybe permeable. This has clinical implications. Patients who are thrombolyzed who have clot characteristics like in B or in C have a higher likelihood of dissolving with intravenous TPA. In our experience, sometimes these clots can actually dissolve super fast, maybe even within 20 minutes of thrombolysis. And so you can look at the clot characteristics on a CT angiogram and get to some estimate about what is the likelihood of this person's thrombus dissolving with intravenous thrombolysis. And this is some data from the INTERSECT study that shows that. If you see the figure here, blue is plotting out patients with permeable clots. Red is plotting out patients without permeable clots. And on the y-axis is percentage successful recanalization, and on the x-axis is time. And as you can see, in patients without permeable thrombus, and this is like LVOs, so these are large vessel occlusions, the likelihood of recanalization in the first 30 minutes is very low, whereas it jumps dramatically to around 40 to 45%, ranging up to around 60% recanalization within the first 30 minutes with intravenous TPA if the person has residual flow of permeable thrombus. And then as you see over time, that possibility of recanalization with TPA increases substantially. In our experience, at least around 15 to 20% of large vessel occlusions or thrombi could have residual flow. The next thing that we do on CT angiograms is assess collaterals. As I showed you in that previous figure, if you remember, collaterals are these backfilling arteries that fill the ischemic brain beyond the occlusion. So you can see here, this person has an M1 occlusion, and you can see the PL arteries filling back. On imaging, we would call them collaterals, although the real collaterals are these tiny arteries, arterioles that are present in the border zones. But this is what is, looking at collaterals. So as you can see, it's quite easy to assess collaterals on CT angiograms. And collaterals predict imaging and clinical outcomes. So if you look at the top panel here, this person has an ICA occlusion on the right side and has poor collaterals. You compare it to the other side, the vessels are very well seen, but on this side, not much vessels. So poor collaterals. And what happened here on baseline MRI for the same patient at the same time, you can see diffusion restriction in a large part of the MCA, and at 24-hour, this patient had a big stroke. The middle panel, this patient has a left M1, mid M1 occlusion, and you can see these vessels beyond the occlusion. You can see some vessels, but they're not really that good when compared to the other side. So this is intermediate collaterals. Intermediate collaterals would mean intermediate infarct sizes, and so intermediate outcomes possibly. This is all conditional on treatment, obviously. And then the bottom panel is good collaterals, a small M1 occlusion. On the left side, you see good collaterals, vessels fill in quite fast. And then you see that at baseline, this patient had, like virtually no DWI changes. And at 24-hour MRI, conditional on treatment, this person did really well. However, when you do what is known as a single phase CT angiogram, which is you acquire from the neck up to the head, the imaging can actually vary depending on the timing of the acquisition. So if you have the fast scanner and your tech injects the bolus a little bit on the slower side, possibly, then you might actually acquire images early, and you may not see the vessels as well, as you can see here. Whereas if you acquire later, then you might actually see vessels better. So single phase CTAs are time dependent, bolus time dependent. And so it can therefore have problems. These are extreme examples, but on the left side, you see we got a scan where we actually acquired the scan very early, which means the scan got done very early in comparison to the bolus. Or maybe the bolus leaked, and then you actually don't see much vessels. Whereas in this case, the scan was actually taken very late, and so it's in the venous phase. So you mostly see veins, although there are some arteries. So when you have, mislabeling of, when you have bolus timing issues with single phase CTA, you may not be able to assess your collaterals really well. So we came up with a very simple technique called multiphase CTA, which is essentially time-resolved CTA. And so you'll see here in this picture, one acquisition, and then you come down, and then low radiation second acquisition, 0.5 millisieverts, low radiation third acquisition, 0.5 millisieverts. So you get 3 different images, and this is what you have. And I've shown you some of those scans earlier too. You have phase 1, you have phase 2, and you have phase 3. This is multiphase CTA. And so you have time-resolved images of PL filling of collaterals. So if you look at the panel above, this patient has a MCA occlusion or IC occlusion, I guess. And you can see in phase 1, the vessels are filling in, the red ellipse. Phase 2, they're filling in really well. And then phase 3, they're sort of starting to wash out. And so you can actually look at the tissue or the contrast density curve and then say, oh, in phase 2, there's a 1 phase delay. It's coming in, it's going out. That's reasonably good collaterals. Whereas with patient B here, in the middle, you can see the vessels filling in the first phase quite well, but then they tend to hang out there. So yes, blood is flowing well, but it's hanging out, which means that there is impaired washout. And then number 3, it's not coming in at all. So you see in the first phase and the second phase and then the third phase, not much coming in, poor collaterals. So this is how we can actually, easily look at the CT angiogram and get a good sense, as the cardiologists do sometimes, of collateral status. And that tells you about salvageable brain. Patients with good collaterals beyond your clot, you should treat. Patients with poor collaterals, the risk is significant. You can also be a little bit more granular for people who are very interested in imaging. You can actually look at collateral status regionally. So in this case, I have actually labeled the M4 region, if you look at my cursor, M5 region and M6 region from the aspects template. Now, and these are phase 1, phase 2, and phase 3 scans. If you look at M6 region on phase 1, you don't see much filling when compared to the other side. On phase 2, not much filling. Phase 3, not much filling. This is poor collateral in the M6 region. If you look at perfusion, it's red, poor perfusion. And then on the follow-up scan, that was that region stroked, although we tried to open up the artery. But now you look at M5 region compared to the other side, vessels fill in. They fill in really well in the second phase, and then there's some delayed washout. This is penumbral region ischemia. You can see that on perfusion. And when the artery opened up, some of the brain died, but some of the brain was preserved. In contrast to the M4 region, where it fills up equally well in phase 1, it is slightly prominent in phase 2 and washes out immediately in phase 3. This is benign oligemia. You can see that on the corresponding perfusion, where you don't see much perfusion defect, and this brain, did not suffer from any damage on the 24-hour CT scan. So you can be very granular with your collateral assessments on CT angiogram too. And there are some new techniques now where you don't even have to look at the three phases. The computer actually combines all three phases to generate time-resolved CTA collateral maps. So red is fast filling. So this is the abnormal side. You can see that the artery is filling in quite well. Whereas here's the occlusion, the white arrow showing the proximal M1 occlusion. And then these are the collaterals. Now, green is relatively faster filling, blue is slow filling. And so if this were all red, you would say, oh, super good collaterals. These are blue, so you are saying intermediate collaterals. This region is green, intermediate collaterals, blue, slightly poor collaterals. So you can look at the color-coded maps, CTA collateral maps, and immediately get a sense as to whether this person has, where the occlusion is, and whether this person has good collaterals, intermediate, or poor collaterals. Remember, if you have poor collaterals, the likelihood of benefit with endovascular thrombectomy is low. So I'll give you some examples just to show that construct. Look at the non-con CT scan here. You will be seeing some changes. Oh, the lentiform is obscured. There's the insular ribbon sign. But otherwise, based on the our approach, I would say, oh, this looks like a reasonably good scan. However, when I look at this here, ICA occlusion, poor collaterals. I don't see anything when compared to the other side. And then this is multiphase CTA, phase 1, phase 2, phase 3, from top, bottom to top. And not much filling, right? Poor collaterals. And you can see that clearly. Anybody can pick that up. And so analysis, non-con CT scan, approximately 5. So it's sort of intermediate-ish, ICA T occlusion, but collaterals are poor. Now, at that point, we were trying to see how patients with aspect 5 or 6 would benefit. And so we took this patient to endovascular thrombectomy after giving intravenous thrombolysis. The patient still had the occlusion. The patient did recanalize, as you can see, really well. However, this is what happened. Patient didn't do well. Had a big stroke because of the poor collaterals and then died. So, imaging helps in assessment, right? Another patient, non-con CT scan of the head, you look at the scan and overall, the scan actually looks good. However, you see the M1 occlusion here, and then you look at the multiphase CTA. Now again, assess your collateral. This should be easy for you now. This is the occlusion. How are the vessels? They look good, right? Reasonably good vessels, even on first phase. And on the second phase, they do fill in, but on the third phase, they wash out, which means blood flowing in very well. These are very good collaterals. Non-con CT aspects, good scan, M1 occlusion, good collaterals. This should be a prime candidate for treatment. We went endovascular after giving intravenous thrombolysis. There is the distal M1 occlusion now, so the clot may have moved a bit. The patient opened up, achieved like TK3, 2C recanalization. There's a distal M1, M4 occlusion. And then on the 24-hour MR, you see that there is, some infarction, but the patient did really well. So patchy infarction in the left MCA territory and then went home. The 24-hour NIHS was dropped to 3. So that's the utility of, just using the CT scans to make clinical decisions. The other users of CT angiography. This is a patient who came to us about a year ago. You see the scan. We do a CT angiogram head and neck, as I mentioned, and therefore we can actually see the aorta. And so here you see that there is, a dissection flap seen in the ascending, the transverse, as well as the descending aorta, and then it extends into the large arteries. The right ICA is occluded, and although the intracranial arteries are okay, this was something we immediately saw, which, we didn't actually give this patient intravenous TPA, and the patient, didn't do as well. Because now to dissections don't have as good a prognosis. This is another patient of ours. Again, during the acute scenario, do a CT angiogram. This patient had a M1 occlusion, but then in the neck, you see what is known as a carotid web. And in our experience, these webs, although they look benign, are not really benign. They cause a lot of problems. So it's good to identify them beforehand. And if you see those things, consider treating them. There are some controversy as to what is the right treatment. There's some literature now to suggest that these patients could also potentially benefit from endarterectomy or stenting, although the evidence is not level bound. We can also, look at, the classic carotid pathologies, large artery disease. This is from the Dutch group, Mr. Klein group. And so in panel A here, you see on the CT angiogram that this is like a shouldering sign. The internal carotid artery is blocked here. And on the digital subtraction angiogram, you see the same shouldering sign. This is atherosclerotic. It was actually hard to take the catheter beyond this. So the procedure was not very successful here. In contrast, you see this tapering sign here on the CT angiogram. This could be a dissection. It could be, intracranial atherosclerotic pathology too, but, this is tapering, and then you don't see much beyond this. Although they were able to take the wire beyond this, I don't think they were actually able, they were not successful with this procedure. That's what the legend said. And then finally here on the CT angiogram, you see what I call is pseudo tapering, which is like you see some tapering, but it's like, like a little bit hazy here, right? This is the classic pseudo occlusion or the false occlusion. And then on the digital subtraction angiogram, you'll see that you're able to push a catheter forward. This can happen if you have a distal IC occlusion, as you see here. Although, on the CT angiogram, it may sometimes be difficult to sort of accurately predict whether this is a complete occlusion or a false occlusion, but there are some clues. And one of the clues is this sort of ghosting appearance in that area. So those are things you can actually look on the CT angiogram and plan your intervention accordingly. I'll come to the last few aspects of imaging. We don't use this as much, but this is CT perfusion imaging. And nowadays you have automated CT perfusion imaging. What is CT perfusion imaging? It is like multiphase CTA. You get time-resolved images, but you actually get significantly more time-resolved images. And then you use a mathematical algorithm to compute the tissue density curve through deconvolution algorithm. So you will have what is known as an impulse residue function. And then you actually calculate using the central volume theorem, the cerebral blood volume, the cerebral blood flow, the mean transit time, or the Tmax. So those are ischemic constructs that you would calculate. And then you would use those ischemic constructs to actually say what is core and what is penumbra. So an example here from Rapid software is, as you see here, the pink area is a region of the brain with relative cerebral blood flow less than 30%. That is the threshold for what is called ischemic core. And then the green is a Tmax, which is the transit time parameter of greater than 6. And that is penumbra. And so in panel A, you see a mismatch between the core, which seems smaller, around 9 ml, and the penumbra, which is around 126 ml. So there's a mismatch. In the same patient, you would see that you'll have maybe an M1 occlusion on the CT angiogram and good collateral. So you would see the collateral mismatch, in the corresponding CT angiogram. Panel B, you see the core seems big and the penumbra seems equally big, so less mismatch. On the CT angiogram, you'll see possibly ICA M1 occlusion, and you will see poor collaterals. So you see that these correlate. However, now what's happening is with some of these core penumbra mismatch constructs, we know that core grows into the penumbra over time. And so what is core based on CT perfusion imaging is changing. And so there is this idea that you could now have what is known as time-based CT perfusion thresholds, which means that depending on when you would potentially open up the artery and when the patient presented, your estimate of what is core changes. And I'll show you an example here. So look at this scan and look at panel A and B here. So panel A, stroke onset to CT time. And then this is panel B here showing imaging to reperfusion time. And so this is the computer making calculations, panel B. So if the patient, if you as an interventionist are able to open up the artery in 1.5 hours from imaging, this is what is likely to happen, if you see my cursor. But if you open up in 3 hours, this is likely to happen. But if you take 6 hours to open up, this is what is likely to happen. So the infarct is growing. And in this patient, we're able to reperfuse around 3 hours from imaging. And so you can see that this is what really happened. And this was the prediction. So the prediction actually matches what really happened because of mathematical computation that takes into account time. And so that is what we now do with CT perfusion imaging. There are certain points to remember with CT perfusion imaging. You must talk to your radiologist to actually understand the type of CT acquisition used at your hospital. And this is because the extent of brain coverage may differ. They may be doing just 4 centimeter coverage or 8 centimeter coverage, or if you have the newest scanners, maybe even 12 to 16 centimeter coverage. You need to know that because sometimes you may just see 4 centimeter and you may miss other areas of the brain. So you need to know that. You need to understand what type of algorithms are used at your hospital. I showed you the rapid algorithm, but we use the GE algorithm, and the Tmax thresholds are different. So you need to know what exactly do you use. You also need to know that if your patient moves, and some of our stroke patients move, even with the most advanced motion correction algorithms out there, that there could still be motion artifacts that confound imaging assessments. And so that is important for you to recognize. If you actually scroll through your CTP images or look at the arterial input function curves, you'll be able to recognize this motion, but it's not easy. And sometimes with automation, they actually provide you images, but they don't actually provide you the backend information. And you may be, you may sometimes get incorrect estimates. And then finally, you must remember that CT perfusion predictions are predictions, that they're not perfect, and that you have to use your clinical assessment, and you have to look at the non-con CT scan. So finally, I just wanted to put imaging in context to say that imaging doesn't operate alone. It operates in the clinical context. And clinical context is Bayesian, which means that as we get more information, we know more about a patient. So in this example, a 70-year-old had hemiplegia, was last known, 3 hours ago, was normal at baseline, so which did not have any previous comorbidities, but has an NIH of around 18 now, is not on any blood thinners, has a blood pressure of this much. You already know that this is a person who's highly likely to benefit from treatment, right? So the probability, posterior probability in a Bayesian framework of this person benefiting is high. And so I'll give you some examples again. So 85-year-old male, right hemispheric syndrome, so focus on the right hemisphere, 2 hours from onset, NIH 24. I would, if I take a poll, almost all of you would say, oh, this patient should be treated. Yes, you're right. But then, we look at the CT scan, and so you're focusing on the right hemisphere. It looks like a good scan, right? So I would say, fair scan, good scan. Now, I pick up a mid to distal M1 occlusion, but I look at the collaterals in multiphase. Collaterals don't seem that good. Very less vessels, especially in the anterior region. So should I treat with IV TPA? Should I do endovascular therapy? Yes, the patient did come in within time window. I would give TPA, but the endovascular has some concerns now because poor collaterals, right? And so that's an issue. So good aspects, collaterals are minimal. Patient did get IV, went endovascular. This is, like some years ago. But we didn't find any major clinical improvement. And as you see with these scans, the patient had lots of patchy influx and didn't do as well. Another patient, 65-year-old, right hemispheric syndrome, 6 hours from onset. This is the new era where, we actually treat 6 hours, 12 hours, even, 18 hours, depending on imaging. So now I look at the non-con CT scan. I said right hemisphere, so focus on the right hemisphere. The scan looks good. So I do see some changes, but moderate looking scan. Proximal M1 occlusion. I see the collaterals, but the collaterals seem, they are filling in the second phase, but they don't seem as good. So intermediate looking collaterals. On the perfusion map, this is the CBV map. I see some lesions with low CBV, which is, like ischemic core, and then a large Tmax region. So moderate mismatch. Treat with IV TPA for beyond time window, so potentially not. Endovascular treatment, moderate collaterals. I'm sort of, thinking what to do. Assessment here, this analysis suggests poor collaterals. Let's see what happened. We went ahead and treated, right? So home with a ranking of 4. So you see, like imaging, tells you potentially what's likely to happen. Last patient, 75-year-old, presents with a right hemispheric syndrome, almost 10 hours from normal, NIH 18. Again, right hemisphere. Scan looks good, non-con CT scan. Mid M1 occlusion. Look at the collateral. So first phase, very good filling. So this is really good collaterals. Look at the perfusion, no CBV lesion, huge Tmax lesion, huge mismatch. Treat with IV TPA, the time is a factor, endovascular, yes. And all in green, so which means good patient, ideal candidate. We went ahead, treated, patient did really well. We had some lentiform and deep M5 infarction. And so this is how we use imaging for a treatment decision making. Now, we must remember again, I want to reiterate the fact that time is brain. The endovascular thrombectomy and intravenous thrombolysis are robust treatments. And therefore, acute stroke imaging that we use, should actually be fast, 24/7 and reasonably accurate. If the imaging doesn't fulfill these qualities, that type of imaging you shouldn't be using. And then remember, the clinical decision-making uses the Bayesian framework. So somebody comes in very early, like within 90 minutes, it is highly probable that I'm going to treat that patient anyway. The only thing that might prevent me from treating is this patient has, like non-con CT shows aspects are 4, collaterals are very poor, and the patient is older, then maybe I may not treat. But otherwise, if the patient presents early, I would treat. But, as the patient presents later, then, imaging becomes more and more important. You must also understand the incremental additive information that imaging provides. In many patients, just the non-con CT might be sufficient. Patient presents early, you see a hyperdense MCA sign, the scan looks good, just go endovascular, give TPA, go endovascular. But in other patients where you're not sure, the multiphase CTA adds more information. And then, you're not sure, maybe the CTP. In our experience, a non-con CT at multiphase CTA are enough for 99% of decision-making. And we never use MR in the acute phase, except, in super complex case. We never tend to use it for acute treatment. So this is what you need to remember. Acute stroke patient workflow with efficient imaging is super important. There are lots of steps, but they have to happen very fast. And at our center, we try to make sure that by the time the patient comes into the door, to the patient getting the scans, to us thrombolizing, to endovascular thrombectomy, to opening up the artery, we try to do it within 90 minutes. So that's important. And nowadays, you have lots of tools to actually help you. So there are, imaging platforms that are available that could actually give you all this information very quickly. That could potentially help you. We have this website that's now advanced to actually include all of the constructs I told you about, including aspects, collateral scoring, multiphase CTA assessments, and everything. So you can go there and check. Thank you.
Thank you, Bijay. It was a wonderful talk. Like lots of concepts got cleared. So thank you once again for agreeing to participate. We have like many questions. Almost 50, I think, have popped up. So first thing so we'll start taking one by one. Just a selected few. Decision making for IV thrombolysis, they say 1/3 of MCA territory. So someone has asked that, how do you decide 1/3 of the territory?
Yeah, so the 1/3 MCA rule, actually came from some of the European thrombolysis trials. Although, the evidence to actually support that is less. But essentially, what it means is, if you're actually looking at your MCA region, and if you look at aspects, right? And aspects of somewhere around 4 or 5 would actually be a 1/3 MCA involvement. But what does that mean? It means that if you already have a large area of brain dead and you're giving intravenous thrombolysis, you will achieve 2 things. Intravenous thrombolysis, as you know, will take some time to open up the artery, if it does. And by this time, that 1/3 MCA may have grown to maybe around 2/3. So it's become a larger infarct.
it's also become more subacute by the time the artery opens up. And so you are now reperfusing damaged brain and large extent of damaged brain, which could potentially, cause two things. One, increase reperfusion hemorrhages, a reperfusion injury, and two, potentially less benefit. And this is why the MCA 1/3 rule, we don't normally tend to use that as much. From an intravenous thrombolysis perspective, for me, the more important risk assessment is the degree of hypoattenuation. If I see that the hypoattenuation is looking subacutish, then I have some concerns about thrombolysis. I don't use the extent parameter as much in my decision making with thrombolysis.
Yeah, fantastic. The other question many have is like, is MRI preferred or CT preferred, as MRI can be done quickly in India? And secondly, what is preferable, is CT angiogram or MR angiogram?
Yeah. So the first question, MR versus CT, as I said, you need to answer this question whether you can do it fast. Now, the problem in assessing that question is because you don't know how fast you can do with a CT if you're using MR, that you really don't get a sense whether CT could be faster or not. As Darshan knows, we use CT. Most North American centers use CT, and we think that CT is significantly faster than MR. However, if you're able to prime your systems to get MR done really fast, then I'm okay with MRs. But you need to measure your times, and then you need to make sure that in all your patients, and not just the patients you successfully treat, that you are actually able to get your MR fast. With regards to MR angiogram versus CT angiogram, there, I think clearly because of contrast that we get with CT angiograms, that the signal to noise is significantly better with CT angiograms. And therefore, from an image quality perspective, the CT angiogram is significantly better. Obviously, you would say, the MR angiogram doesn't use contrast, but, it has acquisition issues and all the other logistical issues that I mentioned. So my preference is to do CTs and CT angiograms.
Do you see collaterals as well with the MR angio? I think CT angio goes on collateral.
No, and that's the point I was trying to make, right? Like the resolution with the CT angiogram is significantly more than MR angiograms. And so when you're looking at collaterals with MR angiogram, yes, you can see it, but let's say you have intermediate collaterals, so the flow is slower, then you may not see it as well. And so there are those issues with MR angiograms if you're using time of flight. Now, obviously, you wouldn't be using gadolinium contrast MR angiograms. And so if you're using, time of flight or phase contrast MRs, you have problems with collateral imaging.
Right. So there's one more question, like in terms of hypertensive bleed. One is, every hypertensive bleed patient, do you require CT angiogram? And do you always require multiphase CT angiogram?
Yeah, no, good question. So do you always require CT angiograms? The answer would be no. However, you never know until you know that this patient has a hypertensive intracerebral hemorrhage. And so, yes, you're right. Like if it's a 60-year-old, 70-year-old, has a history of high blood pressure, presents with typical symptoms, you get a non-con CT, there's a basal ganglia bleed, it is highly likely to be a hypertensive ICH. However, we do use, as I said, the spot find construct to actually assess for a prognosis. So the spot find can only be picked up on a CT angiogram. You are right that at least at this point, we do not have evidence to support the use of the spot find construct for treatment decision making. Although there have been a few trials with factor 7A, and then one is now going to start, but that doesn't use the spot find construct. But it does help us in prognosticating. So if I see the spot find, I'm a bit more urgent in reducing my blood pressure, in potentially maybe taking this patient to a more intensive care unit, talking to the family about prognosis, saying, oh, this patient is likely to worsen. So it helps me with that sort of decision making.
Yeah, really. One more question, is creatinine required before CT angiogram? Because many have doubts out here.
Yeah, so like I referred you to that Mayo Clinic paper. there is really no reason why you should actually order a creatinine and get it. What we do is, as Darshan would know, we actually order the blood. So the blood tests are done, but we don't actually wait for the blood test to do a CT angiogram. And so there is lots of evidence now that it is in a minuscule minority, 1 in 100,000 patients, that you may find an issue. The only exclusion is when we clearly know this is a patient with renal failure history and who's potentially not on dialysis. And this patient has maybe like minor stroke-like symptoms and not like major stroke. It is only in those conditions that we would actually avoid doing CT angiograms. In other conditions, we'll just do it. And we have been doing it for the last 15 years. We have had no issues at all.
Yeah. Can we use aspect score on MR diffusion?
Yeah, there is a problem. Because of the high resolution with the MR, you may actually see more, you may overestimate aspects extent, or like underestimate. So imagine looking at the MR, right? You will see maybe a little DWI lesion in an M1 region, a little DWI region in M2 region. And if you see 10 tiny DWI lesions in the 10 regions, you will score the aspects as 0. So, but that's not the case. So MR, there is a tendency to overcall. What we have done using MR is use a correction factor. So we would only score a region as involved if at least 20% of that region is involved on diffusion imaging. So yes, you can use aspects on MR, but you need to understand that you need to use these thresholds. So each region, at least 20% of that region should have diffusion restriction for you to then call that region involved.
Yeah, because many times MRI will make you more conservative in treating.
Yeah, exactly. So which is why, like I would say that, like you need to be careful when you use MR to measure extent. So.
Right. So if there are subtle flare changes on MRI and not well-defined changes, how would you see that? Like?
Yeah, so the DWI flare mismatch construct essentially, like, although we call it in terms of, like we call it black and white, it is not black and white. As somebody is pointing out, there could be subtle flare changes. Like in my experience, if you see DWI changes in the same region, you see subtle flare changes, that is less of a problem than when you see, clear flare changes. And so it essentially means that when you see subtle flare changes, that is an early presenter or less severe ischemia than somebody who has clear flare changes. So I would go ahead and consider thrombolysis if you have subtle flare changes vis-a-vis, more clearer flare changes. But if you have done a CT, I would look at the CT too. And in that same region where you saw that DWI change and the subtle flare change, if on the CT, you actually do not see subacute looking changes, you just see subtle early ischemic changes, then, just thrombolize.
Okay. How does clot size, clot burden decide treatment management?
Yeah, so like with endovascular thrombectomy, if you see a large vessel occlusion, as an IC occlusion, M1 occlusion, proximal M2 occlusion, basilar occlusion, you should, treat, right? So the location is important. You clearly know that on a CT angiogram. But the extent of thrombus is also important. If you have a huge extent of thrombus, so let's say you have IC occlusion that extends into the M1 and into the M2, that's like a big clot. The likelihood that this clot would open up with TPA is going to be low. And so you will clearly need endovascular thrombectomy with those patients. So the extent of clot, means that there is less likelihood of success with intravenous thrombolysis. And this is, the clot burden score too. And then, as I mentioned, thrombus characteristics, like permeable clot, then you get a better sense that, the clot might actually open up with thrombolysis. So you do need to look at your scans. You need to know whether it's a distal clot or a proximal clot. Proximal clot, consider endovascular thrombectomy. Huge proximal clot, you must think, oh, TPA may not be that helpful. Endovascular thrombectomy may be more helpful. However, the evidence to actually support withholding TPA is currently very low. And the reason is, you may do endovascular thrombectomy in these patients, but then, the clots may dislodge into distal territories and you may not be able to access them unless you have IVTP on board. So there is that issue too. So, it helps decide, helps you make some judgments, but, that judgment is an art, right? So I just gave you broad principles, but then, we can discuss later some cases and
different cases will help in that.
So
other thing is is EVT endovascular therapy decided based on aspects or collaterals?
Yeah, as I said, the broad principle of endovascular thrombectomy is you need to identify your target occlusion. So you need to have an LVO, large vessel occlusion, ICA, M1, proximal M2, basilar. Once you do that, the next thing is you need to identify whether there's salvageable brain. How do you do that on a CT angiogram? You need to have good aspects and or good collaterals. So if you have good collaterals beyond that occlusion and it is a LVO, that is the person who would benefit from endovascular thrombectomy. So it's as simple as that. Occlusion, which is amenable to endovascular thrombectomy, and beyond the occlusion, good collaterals. If these two are fulfilled, that's an endovascular target.
So one more question, how do you differentiate between chronic stenosis versus thrombus?
You mean like intracranially, like let's say an M1?
Yeah.
This is really difficult. There are some clues, but like in my experience, these clues are not really that helpful. So people say, let's say, take an M1 occlusion, right? Like if you have very good collaterals, there is a possibility that this was a chronic occlusion that then acutely re-occluded, so acute on chronic, and the good collaterals are because of this chronic occlusion. But as I told you, it could be the other way around too, where the person has good collaterals with an acute thrombus. You could see some calcification near the arterial silhouette, and that might tell you that, this is possibly chronic occlusion, but you need not see those things too. So some adjacent signs might actually tell you, like calcification might tell you that there is chronic occlusion. You could see post-stenotic dilatation. The vessel might appear wider distally beyond the occlusion. But again, in my experience, when it's a complete occlusion, you don't actually see that sign. So if you talk to some of my South Korean colleagues, they'll tell you that it's actually very hard to say whether it's a chronic occlusion or just an pure acute occlusion. And that the sensitivity and specificity of all these signs that I'm talking is actually low. So it's difficult at this point. There are some newer imaging techniques, like you could actually look at the non-con CT and the CT angiogram, overlay them, and look at what is known as thrombus attenuation index and an epsilon ratio, and then possibly say that this is chronic versus not. But all of these signs are not very specific and sensitive.
Exactly. One more, people want to know about the pseudo occlusion that you talked about, because secondary to this, they wanted to know as to more about it. Multiphase CTA help in pseudo occlusion, like in subsequent phases.
So classically, what really happens is, imagine somebody has a ICA carotid T occlusion. So when you have a carotid T occlusion, now you do a CT angiogram. Contrast is supposed to go through the internal carotid, but then because it's a carotid T occlusion, it's like a cul-de-sac. And so what really happens is contrast goes maybe like 1 or 2 centimeters or up the internal carotid, and then you don't see much beyond that because of this stasis due to the carotid T occlusion. This is pseudo occlusion, because when you look at the CT angiogram, you think that the occlusion is at the neck, but the occlusion is not really at the neck, the occlusion is higher up. Now, as I showed you, one way of distinguishing it from a true occlusion is to look for other signs. So if you see a lot of calcification, and you look at the axial images, and you can see potentially, a plaque-looking appearance, then you can see, oh, you know, there is a plaque there too. So it's not just purely pseudo occlusion, there is a real occlusion there. But there was the other imaging appearance in the Dutch paper, where instead of, you know, like a shoulder effect or a flame effect, you actually see a regular effect. So the contrast is stopped, but then, you know, like there is a sort of, you know, distinct grayish zone that you can see. And that type of appearance could actually be seen with pseudo occlusions. Now, what Darshan is referring to is with multiphase CTA, because it's time resolved, you know, you get time resolved imaging. And so let's say, you know, somebody has a 90% occlusion because of stenotic plaque versus a 100% occlusion. How do I differentiate that? On a single phase CT angiogram, you would see that with the 90% and with the 100%, because contrast is getting in slowly in the 90%, the block is seen at the neck in both cases. Whereas when you do multi-phase, because you now have serial imaging, you can see the second and the third phase, and you'll see the contrast coming up in the 90% occlusion. So you will be able to differentiate between a near occlusion and a complete occlusion using multi-phase CTA. So those are things that you could do using CT angiograms.
Yeah. Thank you, Bijay. We have like many questions, but I think you have answered most of them. Thank you once again from everyone. We had close to 650 participants, so it was a